All right, thank you everyone for waiting so patiently. We had a little technology problems happening that happens sometimes, and we moved through it. Um, Today's webinar is Navigating the Darkness, Assessment and Management of Suicidality in Youth, led by Alyssa Wilburn, PhD, who is a clinical psychologist and assistant professor in the University of Arkansas for Medical Sciences, Department of Psychiatry, and my colleague on the ARBEST team. My name is Riley Thomas, and I'll be your webinar moderator for today. Before we get started, I wanted to let you know a little bit about the ARBEST program and do some housekeeping announcements. Arkansas Building Effective Services for Trauma, or ARBEST, is a state-funded program at the UAMS Psychiatric Research Institute, and our aim is to improve mental health services for children and families who experience trauma. We work closely with multiple partners to build a more trauma-informed state, and we're probably best known for providing training to mental health professionals on treatments that are effective with helping children and families recover from trauma. And now for some housekeeping announcements. If you have questions throughout the webinar, you can type them into the Q&A and we'll get to them at the end of the webinar. Please use the chat feature for any comments or responses, but make sure if you have a question to put it in the Q&A so that we are sure to see it. We are recording this webinar, which will upload to the ARBEST YouTube channel. We have other previously recorded webinars there too, so you can check those out. Be sure to like ARBEST on Facebook. We frequently post upcoming webinars, training opportunities, and other resources there. If you're interested in earning a CEU, just be sure to stick around to the very end, and I'll give some more instructions on how to obtain that. Today's presenter, which I'm really excited about, is Dr. Alyssa Wilburn. She is a clinical psychologist and assistant professor in the University of Arkansas for Medical Sciences, Department of Psychiatry. Dr. Wilburn is certified in both parent-child interaction therapy and trauma-focused cognitive behavioral therapy. She also co-facilitates a dialectical behavioral therapy skills group for teens and their families at the Child Study Center, and recently completed training in the collaborative assessment and management of suicidality. She is here to present on Navigating the Darkness, Assessment and Management of Suicidality in Youth. Welcome, Dr. Wilburn.
Thank you, Riley. For some reason, I can't share my screen. I'm not sure if you're able to adjust that on your end. There we go.
Okay, perfect.
Yeah, I think we got it. Okay. All right. Apologies again, everyone, for the delay. Just having some technical issues on my end. I'm excited to be here today to talk to you all about this really important topic. I don't think that I'm alone in this. When I started doing clinical work, the possibility of having somebody in my office disclosing suicidal thoughts really scared me. And it still does to some degree. And this is often something that clinicians and even other adults who work with kids and teens are afraid of, understandably so. I recently became an in-house trainer for the Components for Enhancing Career Experience and Reducing Trauma, or CSERT. And ARBEST actually sent this out earlier today, if you haven't seen it, but a colleague of mine and I are presenting on this model in April. And one of the ideas proposed in CSERT is that some of our stress comes from situations or feelings in our work that we tend to avoid. And that one way to promote career sustainability is kind of figuring out what makes part of our jobs easier. And one of those for me is improving in some way and feeling more confident in an area that maybe you do tend to avoid. And that for me was suicidality. And so that fell in this category. And so for the past few years, I've really been trying to expand my knowledge and strengthen my skill set in this area so that I feel more comfortable, less scared, and more equipped to respond to these kinds of situations. So my hope for you all today is that you can walk away feeling maybe a little more confident when this topic comes up. Maybe some of this will affirm what you're already doing, or maybe there is something that you hear today that you can integrate into your practice or within your role in your work. So this is our plan for today. I'm going to touch on each of these listed here. I think each of these topics could be a webinar in and of itself. So we're going to aim for breadth today, but I'll talk a little bit about trends and epidemiology related to suicide, talk a little bit about assessment and safety planning, a bit on intervention, and some guidelines for supporting both youth and their caregivers in treatment. And then I'm going to share some resources on postvention, or the steps that we can take following a death by suicide when it does occur. And then I will share some resources towards the end where you can look for training and other information. Given the time that we started today, I'm going to do my very best to leave some time for questions, but I will have my email at the end of this presentation today. And so I welcome anybody to send me questions and reach out if you have questions. So I want to recognize that, participating in these kinds of presentations and these webinars can feel really heavy. And this brings up different things for people for different reasons. So please feel free to step away, turn down the volume, or, do what you need to do to take care of yourself during this hour. This presentation will be uploaded to the ARBEST YouTube channel, as Riley mentioned earlier, so you can access it at a later time when you are ready. So before we kind of get into trends, I just want to make a quick note about language. So language matters when we are discussing these issues. Language matters when we're talking about lots of different things. And the way that we talk about things can really reflect or reinforce unhelpful and sometimes harmful attitudes. So when it comes to suicide, what you'll see here are ways that maybe people have historically talked about suicide that have been harmful, and what are some alternative ways that we can refer to this. So, for example, using terms like committed suicide is often associated with crime, when this act really does not equate to other situations where we would use this kind of language. Similarly, using the terms successful or unsuccessful suicide kind of insinuate in a way that this is associated with being some kind of achievement or accomplishment. And we want to steer away from using that language. It's often better to use person first language as well, not identify somebody by their diagnosis or by their psychiatric presentation, right? So we want to say a person with suicidal thoughts, or a teen that is talking about suicidal ideation. So a lot of the current statistics out there are really focused on teens and youth ages 12 to 17. Some data initiatives also are looking at ages slightly broader, 10 to 19. And that's really because thoughts of suicide and particularly suicide attempts are more often happening in this age group. Although there are some other treatment models and there is, of course, some prevalence of younger kids having suicidal ideation as well. But just know for the webinar today, the statistics and some of the things that I'll talk about are a little bit more related to the teenage age group. Specifically here, right, suicide is the second leading cause of death among people ages 10 to 19 in the United States. And a young person died by suicide every 1 hour and 28 minutes in 2021. And if that is not unsettling enough, in 2022, 3.4 million teens ages 12 to 17 reported having suicidal thoughts, and 1 in 25 attempted suicide. In Arkansas specifically, suicide is the third leading cause of death among people ages 10 to 24. And we're seeing most of that in kind of the later teen years and young adult age range. And Arkansas is ranked 12th in the nation for its high suicide rate. So these are really upsetting numbers, and I think this goes without saying that this is a big concern. So it's important to highlight here that among teens, sexual and gender minority youth are on average 3 times more likely to endorse suicidality. Specifically, 30 to 50% of transgender youth have demonstrated some kind of suicidal behavior during their lifetime. And around 50% of bisexual youth report high rates of suicidal behavior compared to even their lesbian and gay peers. And what we know is that gender affirming spaces kind of across the home, across school, and within the community results in a significant reduction in suicide attempts. If you're interested in learning more about these statistics, the Trevor Project conducts a national survey every year, and they have very comprehensive data on this. So I encourage you to check that out. So there are a few different theories that try and explain what contributes or what leads to someone to engage in suicidal behavior. And these models apply both to adults and to young people, specifically teens. Some of you may have heard of Joyner's interpersonal theory of suicide. This theory really poses that this idea of thwarted belongingness, or feeling socially isolated from people, lacking social support. In the case of teens, that could be their parents, but it could be other people in their life. And perceived burdensomeness, or feeling like you are a burden or a liability to other people, or that you don't matter. That those two things coincide with someone's capability to lethally harm themselves. And that leads to suicidal ideation, attempts, and sometimes completed suicide. And that after kind of repeatedly, for some cases, self-harming, repeated attempts potentially, someone can develop this internal sense of capability. And it's that capability as opposed to a desire for suicide that then leads to sometimes lethal attempts. And then we have Edwin Schneidman. He is an American clinical psychologist and suicidologist. He's kind of considered to be sort of the modern researcher in this area. He illustrates this model of suicide using this cubic sort of illustration. And there's 3 main components. We have psychological pain, we have perturbation, and what we call press. And all of these sort of vary in severity from low to high. Perturbation really is the state of being very upset. It sometimes can involve what's referred to as a cognitive restriction, or this way of thinking that like suicide is the only option. Press is really akin to just actual stressors or maybe imagined stressors in someone's life. And kind of the way that this model is proposed is that if someone is reporting high on each of these 3 constructs, that that suicide attempts is most likely. And so really kind of what we can take from this is the importance of both assessing these different things and even reducing one of these experiences, one of these constructs can significantly reduce the likelihood that we have someone attempt suicide. So there's lots of different myths out there related to this topic. One big one is that talking about suicide is going to encourage or maybe plant the idea of attempting suicide. And what we know is that this is actually an opportunity for communication. So talking about suicide should be managed carefully, and I'll talk a little bit more about that later. But actually what we know is that parents who talk to their teens and their children about suicide really diminishes the fear around this topic and can be life-saving. Talking about suicide, or those who talk about suicide never attempt or die by suicide. That is also a myth. This should be something that is taken seriously. And oftentimes when we have youth who are reporting suicide, this is a plea for help. This is an indication, a verbal communication that I am in pain and I am needing help. Another myth that we hear sometimes is that suicide attempts or deaths happen without warning. And what we know is that suicidal thoughts and attempts don't just happen. Thoughts don't just appear. There are often risk factors. There are often warning signs. And sometimes kids and teens are not able to identify those, right? They might need the help of others to help to kind of connect those dots to figure out, how did this come to be? You know, why is suicide kind of coming up for you? They don't just happen. There's a reason there. And sometimes we just kind of have to take some time to sort of explore that and figure that out. Another unfortunate myth out there is that talking about suicide is an attention-seeking strategy, or that it is a form of manipulation. I will talk a little bit about that later. But one thing that we really want to strongly consider is that if it's attention-seeking, then we need to ask, like, why is this teen, why is this child using this as a way to get attention? Right? We still need to take this very seriously, because we don't ever know. We cannot predict for sure whether someone is going to actually attempt to harm themselves or kill themselves. So it could be attention seeking. And so what, right? This could be an indicator that this is the only way that a child has learned to get their parents' attention or to get an adult's attention. And so sometimes when this happens, when this pattern is going on, you know, teens learn and kind of can get reinforced that, well, I have to resort to saying these kinds of things, right, in order to get help, in order for someone to listen, for someone to hear me. And then another myth is that people who die by suicide are selfish. And this can come with a lot of different sort of belief systems. This is tied to a lot of kind of individual attitudes about things. But what we know is that sadly, a lot of people who experience suicide actually think that other people will be better off without them. And so they're not simply thinking of themselves. They are really tired of living and don't know what else to do. So a lot of clinicians and mental health professionals find it very challenging to ask about suicide for various reasons. And while it's important to ask about suicide, it's also important to have a sense of how you're going to respond, or at least know who you might consult if this arises. So talking about suicide is the best way to determine if someone currently has suicidal thoughts or if they've had attempts in the past. And if we can do this in a calm, compassionate, and sort of matter-of-fact way, this can really open up a door for conversation. And a lot of times, you know, individuals who are experiencing suicide or maybe have had these thoughts before find it very relieving when someone brings this to the surface and at least kind of appears like they are confident in asking about this. It's important to ask direct questions about this and, you know, you use these terms, right? Something like, I've noticed that, you know, you've been going through a tough time, or like, things seem really overwhelming to you right now. You know, sometimes when this happens, people think about hurting themselves. People think about killing themselves. You know, have you been feeling that way? We don't want to ask leading questions. So we don't want to ask questions like, you're not thinking about suicide, are you? Those kinds of questions might suggest that there's a particular answer, or that the provider is hoping that you say, something in particular. We want to make sure to get really specific information. So finding out specific details, maybe about preparation, method, if there's been any attempts before and how many. I'll kind of talk a little bit later about what we want to assess. So there's lots of different assessment tools available. Some of this is kind of highly based on the setting in which you work, what makes sense. Some are more screeners. So they simply kind of ask a couple questions about whether someone's been thinking about suicide or killing themselves or harming themselves. Other tools are a little more comprehensive and can be used during an intake or maybe during a psychological evaluation. So I would encourage you to just kind of explore these and see what makes sense for you. I know the PHQ-A has been used a lot in different settings, and it's a quick way to kind of get a read if somebody is experiencing suicidality, but it is by no means sufficient for assessment of this. So a lot of people associate suicidality with depression, and that makes sense because suicidal thoughts are a diagnostic criteria of major depressive disorder. But suicidality is experienced in other cases, even when a major depressive disorder is not present, or if someone doesn't meet full criteria for that. So depending on how an assessment is conducted, this in and of itself can reduce suicidal risk, right? In general, if we are aiming to avoid shaming, if we are approaching this in a collaborative, we want to understand your experience. We're not going to have, really punishing sort of responses about hearing about this. That can go a long way. I'm not going to go into detail on all of these constructs that we want to think about assessing, but a lot of these are correlates to and risk factors to suicidality and potentially suicide attempts. One thing I do want to point out is access to means, right? Especially for maybe kids or teens who have identified and verbalized a method. That's very important to assess, right? We know actually that a lot of people who experience suicidality are ambivalent about dying. They don't know what else to do. But if we know that in a crisis, they have an idea of what method they would use and they have access to that, we need to make sure we know about that. We also know research shows over and over again that high family conflict, low parental monitoring is associated with suicidal ideation, even after controlling for lots of other factors. So really kind of getting a sense of what's going on in the family, what are some of the dynamics. Another thing too is to ask about beliefs related to death, right? Depending on the age of the children that you work with, they have sort of developing beliefs about death and their understanding of that. Some people have different religious beliefs that are tied to death. Some people believe that they might be reunited with a family member or a friend who has died, right? And that would be really important to know. Another important aspect of assessment is just monitoring behavior, looking out for some of the things that we know tend to indicate that someone is in distress. Someone might be thinking about suicide or likely to follow through with some things that they've been thinking about or planning. These do not mean that suicide will happen. Unfortunately, we cannot predict suicide, but they are very important things to pay attention to. So explicit statements about suicide or death, even if this is talked about in a casual way, we need to pay attention to that. We need to follow up about that. Sometimes giving away prized possessions, an increased focus on death, like death-related topics. This could be through writings or drawings, or maybe researching weapons or medication dosage. So really having good monitoring on those things. And we need to make sure to check in after stressors in major life events, especially following loss. Even when a child might appear okay after a stressful experience, that's a really, really important time to check in. So again, research shows kind of over and over that suicide contracts don't work, right? This sort of either verbal or written agreement between provider and patient that, like, you will not attempt suicide, you will not complete suicide. This often results in a power struggle. And so those don't work and are not usually therapeutic. Safety planning, on the other hand, while it's not treatment of the suicidality, it is still a very important component of treatment. And it is a way that we can sort of in the immediate manage this acute risk. So there's lots of different safety plans or templates out there. A popular one is the Brown or Stanley Brown safety plan. Other models call it a stabilization support plan. Really, there's some key components across and overlapping sort of components across these. Warning signs, different thoughts, different feelings, different situations where someone might be more likely to think about suicide. Options for coping, both sort of cognitively based, also behaviorally based. List of people for connection. We know that social isolation, again, is a high risk factor for suicidality. Making sure people are as connected as possible or have some sense of support. Professional resources, and then means reduction. And I'll talk about that in the next few slides. So I've mentioned this already, but suicidal crises are often very difficult to predict. It can escalate rapidly, and they're often brief. A lot of times suicide prevention efforts are focusing on why people attempt suicide and aim to reduce those feelings. But how a person attempts suicide, in particular the method in which they're thinking of using or have used, can determine whether or not they live or they die. And so this leads us to think about means reduction or reducing access to means. So how amenable kind of each method is to reducing access and kind of managing access around it depends on a few different factors here. One is lethality. How lethal is the method that is being brought up? How is it irreversible or not? How accessible is it? And what is the acceptability or the tolerance of that method? Meaning, is this a method that a lot of people tend to resort to? Is this maybe seen as a more acceptable way for different reasons of a way to harm myself versus maybe something else? So you may be able to see here the relation between various methods and these different factors. So for instance, towards the bottom of this chart, firearms is high across the board in terms of degree of lethality. It's irreversible. It can be highly accessible depending on the home environment. And oftentimes, unfortunately, it is a highly acceptable method of harming or killing oneself. On the other hand, attempted overdose is high in accessibility. Oftentimes, people have pretty ready access to medications within the home. But what we know is that this is actually a lower in lethality, and in some cases, thankfully, is reversible. That's not to say that attempted overdose, even if it's not fatal, doesn't cause life-changing outcomes. We know that this can be incredibly damaging on the bodily system and the brain in lots of different ways. So in general, safety plans really need to involve discussions around reducing and restricting access entirely to means, and then recommend some other ways to do this. Okay. Of course, if you have a child or a teen who is bringing up any other method of killing themselves, that is something that you want to discuss further. That is something we, maybe need to do a little more research on how to reduce access or manage that risk. I want to talk a little bit about firearms because these are used in most suicidal deaths, even among teens. And as I talked about, and as you all are aware, are highly lethal. And again, depending on the home environment and how secure firearms are, they might be highly accessible. So this becomes a really important aspect when we're talking about restricting means and reducing access to means. Arkansas, unfortunately, has the weakest gun laws in the country and has one of the highest rates of gun deaths in the nation. And I say unfortunately in the context of, suicidal risk, right? There are important reasons why people own firearms. There's a lot of values tied to that. But for the sake of thinking of potentially a child who is having suicidal ideation, who might be considering using a firearm as a way to kill themselves, there's not a lot of laws in place in the state that ensure that guns are properly stored, or that there are parameters in place to make sure that adults are keeping guns and locked up in a secure fashion. So the best way to reduce access to firearms, and the safest option, is to store them outside of the home. So there's a few different options here. Of course, if we are thinking about giving our firearms to, a family member or friend, we need to make sure that, there's not kids in their home that, might be at risk for this either. And that there's no one that is, for whatever reason, like not able legally to own or possess a firearm. If this is not an option for families, if there's a lot of pushback, if there's a lot of resistance around this, there are some other alternatives here, right? Of course, a gun safe or a lockbox is important. We would recommend that whoever is sort of the owner of the combination lock, who manages that, presumably some adult in the home, that combination's changed frequently, and that, wherever that is stored, if that's written down somewhere, that is not accessible. Possibly storing ammunition like offsite, outside of the home, or just in a separate kind of area from where the firearm is stored. We can consider removing the firing pin or some other critical component that will not make the firearm even workable. So again, if storing firearms or removing firearms outside of the home is not possible, then those are some other things to consider. Hiding guns meaning like hiding a like loaded firearm and kind of putting it in a place where maybe we don't think kids know about or will look. Not recommended, because as we know, teens are usually more aware of things than we give them credit for. And in the case of a crisis, do we want to risk, them kind of going through the house and looking for something like this and finding it? Medication overdose is the most frequent method for suicide attempts. And they're, like I said earlier, easily accessible in most homes. So we have some guidelines here, ways to reduce access to certain types of medication, managing the quantity of medications available. So for example, we would recommend disposing of all like unneeded or maybe expired medication in the house. Only keeping very limited quantities of over-the-counter and prescription medication, that if someone were to take all of it, that it would not be lethal, or potentially, life-changing or damaging. Removing opioids from the home, so locking up, or just getting rid of entirely, opioids and prescription pain medications like oxycodone and methadone, morphine. Those are very dangerous, especially in combination. So locking up prescription painkillers, anxiety medications, amphetamines, sedatives, tranquilizers, or again, removing those entirely. If they have to stay within the home, we can consider a steel kind of toolbox or a lockbox with a padlock, and that's recommended, because unfortunately the inexpensive lock boxes can be easily broken into. And kind of when in doubt, consulting a pharmacist or calling the poison control hotline can be good resources to figure out types of medications, lethal doses, and kind of combination. So a little bit about intervention. There's lots of interventions or treatment modalities that help address suicidality. This is not a comprehensive list. What we know is that dialectical behavior therapy, or DBT, has the best evidence for helping reduce suicidality in youth and in adults, for that matter. It is considered to be the gold standard treatment for that presenting concern. But there are some other treatments out there that are also helpful and maybe more fitting, depending on each family and child circumstances. One thing I did want to point out is, and this is a framework that I recently became trained in, is the Collaborative Assessment and Management of Suicidality, or CAMS. So this is not necessarily a treatment modality, but it's a framework to help clinicians and guide them through assessment and identifying what are the drivers to suicidality. What is it that is really contributing to these thoughts? And there's lots of different treatment approaches that can be used to address those drivers. But it's really this idea that we can treat suicide as a symptom, as it's presenting. Sometimes we have been trained to address other symptoms or use other treatment approaches to address a diagnosis in hopes that it will indirectly reduce suicidality. But we can treat the suicidality straight on. So I encourage you to look into CAMS, and I'll have more information on that later. So when we are working with kids and teens in treatment, we just want to be sure that our expectations are clear with them. There's a lot of fear around talking about suicide. That might be because of messages around what this means. It might be because they disclosed suicidality to a previous provider and got straight sent to the hospital. And it maybe was not a great experience. So we want to recognize fears around that. We want to be clear about kind of our expectations and in terms of confidentiality, what is shared with parents. And also when, what would lead us to refer to the hospital, right? A really big thing here is working to understand a child's perspective. Again, avoiding judgment about the idea that they're even having suicidal thoughts, that maybe they've attempted or tried to harm themselves. We want to validate and praise like any sharing of experiences, and be transparent and approach this in a collaborative way. A lot of times we have parents that come in to the clinic, to an appointment, and they are really scared. They are very fearful. Sometimes that can come out as anger. Sometimes that's interpreted from kids as like, this is shameful. My parents are not able to hear this information. Depending on the circumstances, that can really lead a child to not then disclose when they're thinking about this, right? So really, we want to try to be, in our role, someone who wants to listen, wants to hear about this, wants to try to help in the best way that we can. Sometimes we're the only adult that has been curious about this and that has really taken the time to sit down and just hear their experiences as raw as they are. And on the caregiver side, supporting a child and caring for a child who has suicidal ideation and potentially past attempts is really tough. It's very stressful. And so parents can be reassured when, they're given a little more guidance on how to ensure the safety of their home, if they're willing to collaborate on that. Ultimately, kids need to feel like they can trust their therapist. And so kind of backdoor conversations or like emails, phone calls from parents about updates, while maybe important, can negatively impact the trust. So again, if there are issues and there's resistance about engaging in treatment from the child or the teen side, we can try to work around how do we best ensure and how do we maximize the level of trust for the sake of saving their life. And again, we know that parental validation of a child's experience is a very, very strong component, and can be life-saving, right? When parents are able to verbalize, that they see their child's experience. They're not going to agree with the option of suicide. They're not going to validate that suicide is the way to cope, but they can validate the experience, and that there's lots of situations in life that are incredibly challenging and might lead someone to think about this. We want to try to identify any sort of patterns related to suicidality. Right. I mentioned this earlier in the webinar, but sometimes kids learn, I only get my parents' attention when I express these really serious thoughts. Like, my pain is so bad now that like, this is what I'm resorting to. And this is the only way that I can get my parents to respond to me, any sort of support, right? So we need to work to identify when that's happening and figure out some other ways. And in efforts to, support kids in treatment, we don't want to necessarily invalidate parents. We are not working to change beliefs and attitudes about maybe different things, but we are working to kind of identify and bring to the surface patterns that may be putting their child at risk more, right? Sometimes depending on religious beliefs around suicide, there's certain messaging that families kind of communicate about. And while we don't necessarily need to change those beliefs, we do need to point out that maybe some of that messaging is just not helpful right now. That is contributing to, not disclosing information, right? That's putting your child's life more in danger right now. So a lot of mental health professionals ask, how do I know when to hospitalize? This can be a really heavy decision to make sometimes. Unfortunately, there is not an algorithm. There is not a formula and cut and dry answer here. We just can't predict suicide. And what we have to do is consider the unique circumstances of every case and decide whether the combination of risk is enough to justify hospitalization. Right. Research shows, unfortunately, that hospitalization does not help reduce suicidality and actually, in some cases, increases the risk. Right. We want to consider how lethal are the plans that are being talked about, right? If a teen says they're going to go drown themselves in a shallow pool that's close to their home, that's really difficult to drown in. How lethal is that, right? We still want to take what they're saying seriously and assess if they're thinking about other ways to harm themselves. But sometimes we can be really reactive to those kinds of statements, right? Of course, document, right? A lot of mental health professionals are afraid of being sued. Remember, we are judged on our practice and our efforts, not on the outcome. So we have to remember sometimes that it's malpractice litigation and not mal-outcome litigation. In the event that someone does die by suicide, I do want to share these resources with you all. This is also a shameless plug for our Trauma Resource Initiative for Schools, or TRIS program. I'm a member of the Crisis Consult team, and we serve as a thinking partner for school personnel in preparation for loss, but also in the aftermath of loss of a student, a staff member, or parent. And you can find more information on how to contact us on the TRIS website. And then just want to share some other resources to consider exploring, some other trainings. If you're interested in learning a little bit more about means reduction, the Counseling on Reducing Lethal Means through the Zero Suicide Institute is a great one. It's free, takes a couple hours, and kind of goes through some statistics and has some example scenarios, both adults and teens, on how to respond and what to think about with different methods. And then here is the webinar code for today. The webinar code is 0103. Again, that's 0103. And as I mentioned earlier, I know I had to talk kind of quickly today to get through things. We may or may not have time for a question, but I am happy to be a contact for any of you all. Please reach out with any questions, and thank you all for being here today.
If you have a question, just put it in the Q&A and we will get that answered. While you're thinking of your questions, I'm going to go over some housekeeping announcements. If you're interested in getting a CEU for attending today's webinar, the code for today is 0103. So write this code down. You'll need it later. After we're done here, I'll send out an email with the survey to everyone who registered for and attended today's webinar. Then you can fill that out with the code 0103, and you'll get a CEU certificate emailed to you after that. We will keep this slide up a little bit so you can write the code down. If there are any questions, put them in the chat or in the Q&A, sorry. Looks like we don't have any. So thank you again. Oh, okay. So Susan Stewart. Hey, Susan. Thank you very much for your presentation. I'm interested in the TRIS program. I'm curious if there are ways to participate. Alyssa, you want to answer this one?
Sure. If you're thinking about the crisis consultation, if you go on our TRIS website, there's a way that you can contact TRIS directly to get in touch with the crisis consult team. We can provide resources to schools, and we can, again, sort of be a thinking partner, around sort of traumatic situations that schools might experience. TRIS also offers free trainings. And so if you go to the TRIS website, there are also information on there on how to register for those different trainings. I'm not sure if I answered your question or not, so please feel free to type more in the Q&A.
All right, I think that is it. Thank you again, Dr. Wilburn. Our next webinar is going to be April 25th at noon. That's April 25th at noon. The topic is components for enhancing career experience and reducing trauma. And we hope to see all of you there. Thank you, everyone, and I hope you have a great rest of your day.
Bye, everyone.
Bye.